Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. We have here a patient who attended with a really severely blocked right ear, and the patient had admitted to using a Q-tip, what we call in the UK a cotton bud, and as you can see, this wax is really heavily impacted right up against the eardrum, and it was causing them quite a lot of discomfort. This wax is obviously quite mature, it's been there for a while, it's oxidized, you can tell by the colour. Freshly secreted earwax takes on more of an orangey light brown shade, but this is turned quite dark brown, almost black in patches. I initially presented with the Zollner suction probe, but as soon as I made contact with the surface of this wax, it was just too dry and hard. So I decided to see if I could use an ear hook and insert. There's a tiniest of gaps just at the roof of the ear canal. Now, we are on the bony part of the ear canal, which is extremely sensitive. So whenever you work that deep in the ear, you've got to be really, really cautious. And if anyone has had earwax removed before and it's been deep and the specialist has made contact with the bony part, you kind of realise what I mean. It can be really unpleasant and painful, really a sharp acute pain. I've had my bony part of the ear canal poked and prodded before in the past, and it was not a nice experience at all. And I can still almost feel that and remember that pain that I experienced at the time. So for me, first and foremost is to ensure the patient is comfortable at all times. I don't want my patients to experience any discomfort wherever possible. Now, sometimes earwax can just be a painful procedure because they already present with pain, and there's nothing you can really do apart from potentially instilling some localized anaesthetic, which as an audiologist we're not allowed to do in the UK. So the ear hook was just a bit too chubby. I then used an ear pick, and I did manage to dissect some of this wax, the surface of it at least anyway, but it was really dry and crusted. And although I didn't really extract anything, I did manage to just bring forward the top part of the plug of wax and skin here, just enough to see if I can get a grip with the forceps, but as you can see, it's still very difficult to get the purchase here. This earwax plug and dead skin plug is also quite matted. It's like a nest. You can see all those hairs that are embedded within the core of the wax plug. So earwax plugs are essentially made up of 3 primary ingredients, or I would say 4. The majority of an earwax plug consists of dead exfoliated skin cells. So the skin that lines the ear canal, as it dies and sheds, it naturally migrates sideways out of the ear, and during that process the skin cells they begin to detach from one another and they exfoliate, they flake off into individual skin cells. So the core of the wax plug, the matrix, the scaffolding, if you like, the meshwork is the dead skin cells, but also loose hairs like this. And filling in the gaps, the remaining 40% is sebum, which is a lipid oily secretion also found in our scalp. And sebum is secreted by the sebaceous glands, and it consists of organic compounds such as alcohols, squalenes, cholesterols, long chains of saturated and unsaturated fatty acids, and an oily sweat called cerumen, which is also found under our armpits. And these are secreted by specialized modified apocrine glands. They're exclusive to the ear canal under the armpit and in your inner groin region. And as I said, they secrete more of an oily sweat. And so the sebum and the oily sweat fills in the matrix, the scaffolding created by the dead skin cells and the hairs. And that's how you develop a skin plug. Now, this patient, of course, had pushed this in. You can see the back part of the ear canal is quite red, the posterior part, so that's where the impaction was. They have the ear canal, as we approach the eardrum, does narrow, and that's normally the case for most of us, but then the ear canal should just widen back out. But I would say this patient's medial part of the ear canal is a bit narrower than the norm. Now, it could just be a bit of swelling, inflammation, because they've been poking and prodding. But otherwise, the eardrum's okay. It's a bit dull in appearance, but again, got to remember the wax plug was directly sitting on the eardrum. So I'm quite happy with that. Patient could hear much, much better. And this is their left ear. Again, you can see they've been poking and prodding in there. There's just the smallest gap. We can see the top part of the eardrum there. So initially, I think I presented with an ear pick, and I'm going to try and get it through that gap and then get in behind. But we've got to be careful here because we're on the bony part. The eardrum is in very close proximity, and that ear pick is quite sharp. It's pointed, so one false move by me or the patient, you could quite easily perforate the eardrum. But we do have a brace, so if the patient does move, we can stabilize that movement. So I did manage to get the ear hook in and behind, but as I was bringing it forwards, it just wasn't bringing the wax out. So I've decided to change the angle of attack, and I'm going back to the suction and just working at the front part of the plug now, trying to lift it, elevate it off the back canal wall, and it's really strongly adhered. When you're using a Q-tip and cotton bud, and if you've got dry wax already, it can really cement itself against the side walls of the canal. So I brought it forwards enough for me to glide in the forceps, get the bottom jaw of the forceps in and behind and in between the wax plug and the canal wall. So we can got the majority of the plug out. There is just some now dry, crusted, dead skin and wax more anteriorly on the front part of the ear canal. And when you're working on the left ear and you're a right-handed person, so you're holding the instrument in your dominant right hand, in the case of the left ear, it's always a bit tricky because there's the potential for your hands to cross over. And that's where you have to use the endoscope to stretch the ear canal to the right and then enter with the suction probe. If you lead with the suction probe, and some of the viewers may not be interested in the technical aspects, but just a lot of specialists that we've trained, the ClearWax training courses, and so it's a good tip just to remind them. You need to use the side of the endoscope, the right-hand side, to push the cartilage near the entrance of the ear to the right, and then look inside the ear. Use the instrument, so I'm using the fine end, to push open the ear canal further, and then go over the top of the endoscope tip so you're safely in the ear. And that technique prevents your hands from getting crossed over. It means you can go quite deep in the ear, especially in this region, the anterior recess. If you lead with the instrument in the left ear and you're right-handed, if the wax is kind of halfway down the ear canal, it's fine. But as soon as you go a bit deep into that last third, you'll find that you're limited in your movement, and the suction probe you lose control of it. It can sway side to side, which obviously you don't want to be doing. So I've just suctioned some oil there. And so we use some oil just to loosen this. And when we use the oil, the patient, you may have seen, has got some hairs at the entrance of the ear canal. Most of us do. That's quite normal. I wouldn't say it's an excessive amount, but there's a few long strands and the oil can sometimes smear against that. So again, I'll just stretch the entrance, and I'm just trying to glide us away. And again, the front part of the ear canal for me is always the most sensitive, whether it's the left or right ear, irrespective of the technique. For me, the front part is always a bit more uncomfortable if you do make contact. I think there's a bit more blood supply there, a bit more neural activity, so is therefore more sensitive as a result. I'm just trying to get underneath this. Truth be told, is it's going to really affect the patient's hearing? Probably not, but because it's cemented, I'm not sure whether this is going to naturally migrate. Sometimes when you've got some skin or some wax and it's sitting loosely on the surface of the ear canal, you're confident that will naturally migrate. But here, because it has been really pushed up against it and it's cemented itself, there's a chance this may not naturally migrate. So if I can, if at all possible, I just want to remove as much as possible anyway. So we got a nice piece out there, and I'm just going to work on the top part here. There is some oil still left down the patient's inferior recess, so at this particular angle, you can see the top part of the eardrum, but you can't see the bottom section, the southern hemisphere, and that's because the ear canal, it drops downwards near the eardrum and it creates a little base in there, a little trench, and there's some oil trapped in there. So once I remove this, I'm going to go back and suction that out. So again, a couple of the hairs are just slightly getting in the way, but it's not enough to really affect what I'm doing. Managed to peel that away. Brilliant. And then there's just a bit at the entrance. Again, that's more staining, residual staining of the wax. I'm not concerned by that. It's not, it wasn't cemented like the sections I removed. There's just a bit of loose hair strand and a bit of wax just there to the left. I don't know whether I'm going to be able to get that because it's almost over the top, and over that kind of little peak. Then probably running the risk of making contact with the canal wall there. I think there's still a little bit of oil there, so I'm going to see if I can remove that. So I'm just getting the position. I think I managed to get it on this occasion. I'm really pleased with that. So that's the patient's eardrums, fully visible. That's the dark, impacted, crusted wax and skin I removed from both ears. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.